Good evening. Welcome to the fourth session of IACTACON Virtual IACTACON 2021. I would like to introduce Dr. Uday Gandhi, who is the moderator for this session. Over to Uday.
Yeah, thank you, Sandeep. Very warm welcome to the fourth session, which is going to be on the cardiac anesthesia and comorbidities. I have a privilege of introducing highly esteemed chairperson, Dr. Mahesh Vakamudi from Sri Ramachandra Institute, Chennai, and Dr. Brigadier Vipul Sharma from DY Patil Medical College, Pune. We have Dr. Harish Vakamudi from Super Specialty Hospital, Nellore, and we have Dr. Satyajeev from the colder side of the planet, London Health Sciences Center, Ontario, Canada. May I hand it over to all the chairpersons to introduce three speakers, please.
Hi, it gives me great pleasure to be here. It's indeed, I feel considered an honor to introduce our first speaker for the day. It is Dr. Satyajeev Mishra, somebody who we need no introduction, a very proficient orator, clarity of thoughts, very crisp talking, crisp points. He is additional professor at AIIMS Bhubaneswar. He has about 16 years of experience in cardiac anesthesia. He has about 45 international and 15 national publications, have delivered over 40 guest lectures. His special interests are in echocardiography, depth of anesthesia monitoring, neuroprotection, bowel recovery, and RE function. He's going to talk today on strategies to minimize pre-operative anemia in patients undergoing adult cardiac surgery. Over to you, Dr. Mishra.
Dr. Sharma, you can introduce the second speaker.
Good evening, everybody. Firstly, I'm honored to be given this opportunity. I would like to introduce to you Dr. Pradeep Goyal, who is the Clinical Director, Senior Consultant and Head of Department of Anesthesia and Critical Care at Narayana Multi-Speciality Hospital at Jaipur. And he will be talking to us on perioperative atrial fibrillation, a challenge for the cardiac anesthesiologist. Over to Dr. Harish to introduce the third speaker.
Yeah, good evening, one and all. I think all of us know about Dr. Kumar. He's a senior consultant and head head of cardiac anesthesia from Meenakshi Mission Hospital, Madurai. He had around 20 national papers and around 50 guest lectures so far he has delivered. And his interest is in TE and perioperative diabetes management and critical care in cardiothoracic surgery. And he will be our organizing secretary for the next 2022 IACTACON. Thank you. Over to Kumar sir.
Thank you all chairpersons. We can start with our first speaker.
So a very good evening to all of you. And I'm Dr. Satyajeev Mishra from AIIMS Bhubaneswar, and I'm here to talk about the strategies to minimize perioperative anemia in patients undergoing cardiac surgery. Over the next 10 odd minutes, we'll go through the problem statement of anemia in cardiac surgery and what are the various strategies to deal with this entity. Now, when you look at the definition of anemia, the WHO defines anemia as less than 13 grams percentage in men and less than 12 grams percentage in women. In India, the prevalence of anemia is around 23% in men, and it's double in women to the tune of 50%. The prevalence in cardiac surgery population is to the tune of 16 to 54%, and it's no surprise that 40 to 90% of patients end up getting transfused after cardiac surgery. Now, the problem is that blood loss is everywhere in cardiac surgery. For example, patients are on antiplatelet or anticoagulant drugs. These procedures are highly invasive, which involves systemic anticoagulation and taking the patient on an extracorporeal circuit. So anemia is just one of the many things that complicates the problem. But when you look at which is the lesser of the true evils, anemia or transfusion or both, now problem with anemia is that when you have preoperative anemia, it results in increased mortality. Not only that, it increases the risks of acute kidney injury, stroke, infection, and so on and so forth. And when patients are anemic, they are more likely to get transfused. Even with mild anemia, the risk of transfusion is 1.44 times than with no anemia. And the problem with transfusion is that even 1 to 2 units of packed cells significantly increases the morbidity and mortality in patients undergoing cardiac surgery, especially coronary artery bypass graft surgery. So the concept of patient blood management has come about, which is nothing but an interaction between anesthesiologists, cardiothoracic surgeons, perfusionists, and that should lead to a more conservative blood conservation practice. And this is amply highlighted in the 2017 IACTS and IACTA guideline on patient blood management after atrial cardiac surgery. So we'll just go through what are the various risk factors for increased blood loss in patients who are presenting for cardiac surgery. Age is always a risk factor. So older the age, more the chance of blood loss. Female gender is a high risk for blood loss. The small body surface area, patient tends to lose a small volume with a small body surface area, so that becomes a significant blood loss. Use of dual antiplatelet therapy like aspirin and clopidogrel. Patients who are posted for complex surgeries like redo or vascular surgeries are at significantly increased risk of bleeding and perioperative anemia. And patients who are having renal insufficiency more often than not have increased risk for blood loss and anemia. So when you look at the various strategies that you have in your hand for dealing with preoperative anemia, and we will go with the WHO definitions. For men, it will be less than 13, and for women, it will be less than 12. So when you're looking at strategies for such patients in your preoperative clinics, if the surgery is elective in nature, then consider postponing such surgeries for at least a couple of weeks. For the iron implementation programs, especially in the form of intravenous or oral irons to be supplemented, and that can bring up the hemoglobin level for the conduct of the surgery. If your patient is exhibiting signs of heart failure, careful diuresis is often indicated in such patients to decrease the level of anemia and improve the perioperative outcomes. There have been some trials where erythropoietin has been used in patients to increase the hemoglobin, but then it confers an increased risk of thrombosis. And if patients are hypertensive, there is a chance of worsening of hypertension. Therefore, the value of erythropoietin is doubtful in combating preoperative anemia. But what is not recommended is there is no evidence for transfusion. Rather, it is clear that transfusion to correct such anemia in the preoperative period is more often than not associated with harm, and hence it is not recommended. Now, when you look at the intraoperative anemia, obviously when the hematocrit drops from 30 towards less than 20, the incidence of adverse effect increases significantly, like stroke, cardiac dysfunction, mortality, renal dysfunction, and respiratory failure. So a safe intraoperative hematocrit to target is between 20 and 24%, especially on the cardiopulmonary bypass. So what are the various intraoperative strategies that we have in our hand? As anesthesiologists, we are primarily responsible for administering fluid to patients. Therefore, fluid should form one of the most important strategies in minimizing intraoperative anemia. Too much of fluid can hemodilute the patient, and by the time the patient goes on pump, the hemoglobin levels can come down substantially. In centers which routinely practice retrograde autologous prime, that can be used where the patient's own blood is used to fill the priming circuits in the venous reservoir rather than adding exogenous prime. Conventional or modified ultrafiltration can always be tried in an effort to minimize the intraoperative anemia. Cell saver can be used in indicated cases like complex cases or redo cases. Antifibrinolytics have a class 1 recommendations, including in patients with undergoing coronary artery bypass graft surgery. This is as per the Society of Thoracic Surgeons guidelines. And always consider if you can go in for an off-pump or minimally invasive cardiac surgery technique, as the risk of coagulopathy or the blood loss is much less with these techniques. So we'll look at some of the strategies and see whether they work or not. If you look at ultrafiltration, there was this meta-analysis in the EJCTS in 2006 that showed that if patients are undergoing ultrafiltration of some sort, either conventional or modified, the transfusions in terms of units of blood or the total volume of blood is significantly decreased. But what about a cell saver? Well, this meta-analysis in 2009 in anesthesia analgesia pretty much showed no advantage of using a cell saver as far as minimizing the anemia and the transfusions are concerned. Not only that, there was no significant clinical benefit in patients who received a cell saver than those who didn't. Antifibrinolytics, there was a very good trial in 2017 in the NEJM, which showed by the ATACON trial investigators, which showed that when you use tranexamic acid in patients who are undergoing coronary artery bypass graft, the total number of units of blood that were transfused during the period of hospitalization was significantly less in the tranexamic group as compared to the placebo group. So also was the rate of major hemorrhage or re-exploration. Yes, seizures did increase. Did increase in the tranexamic acid group, and that's a known side effect or a known complication. But what didn't increase was the risk of thrombotic episodes in patients who underwent coronary artery bypass graft. So if you're thinking that tranexamic acid causes an increased risk of thrombotic episodes, think again, it doesn't. What are the various other intraoperative strategies that we have in our hand as anesthesiologists to minimize the intraoperative anemia and the blood loss? Well, keep a pH of, if you keep a pH of less than 7.35, that means if the patient is acidotic or if the lactates are more than 4 millimoles per liter, then this confers an increased risk of bleeding, anemia, and transfusions. So try and keep the pH between 7.35 and 7.45 and your lactates less than 4 millimoles per liter. Maintenance of normothermia is paradigm to the minimization of coagulopathy, blood loss, and anemia, especially after separation from cardiopulmonary bypass. And you can do this by using warm fluids and by using forced air warming. The surgeon is obviously an important aspect in the prevention of perioperative anemia, and therefore the reduction of duration of CPB is one of the most important factors which is in the hands of the surgeon, and post-CPB meticulous hemostasis is also very important. Provide a coagulation-friendly environment to your patient in decreasing the blood loss. So too much of protamine is never a good thing. If you have to reverse protamine, if you're going for a full 1:1 reversal, it should be only for the first dose. Otherwise, if you're going for reversal of the total dose of heparin, then the protamine should be given in a dose of 0.8 to 1. That means 0.8 of protamine to 1 dose, in a ratio of 0.8 protamine to 1 dose of heparin. Or you can keep a total dose of protamine limited to 4 milligrams per kg. So if it's a 50 kg man, no more than 200 milligrams of protamine. One of the fluids that you should avoid in cardiac surgery is colloids, because it increases the risk of bleeding, and therefore by virtue of that, it increases the risk of anemia and blood transfusion. When you look at the spectrum of post-operative anemia, you'd be surprised to know that nearly more than 40% of patients, almost 50% of patients are anemic even 60 days after cardiac surgery. And the problem with that is every 1 milligram percentage decrease in the hemoglobin increases the cardiovascular morbidity by 13% and the overall mortality by 22%. Having said that, there are studies that suggests that patients tend to tolerate post-operative anemia better with the rehabilitation schemes. So the target hemoglobin should be around 9 gram percentage and not too much. So what are the various safe practices for minimizing post-operative blood loss is, again, fluids. Avoid too much of hemodilution, so a restrictive fluid strategy is good, and early feeding should always be encouraged to try and prevent administration of exogenous fluids. Go for careful diuresis if your hemodynamics permit it, because there's always a waterlogging syndrome in the patient after cardiopulmonary bypass. And limit the amount of blood withdrawal that you do for such patients for various investigations and so on and so forth. So if you can avoid an arterial blood gas, then please do so by all means. Too much of it is going to obviously land your patient into an anemic state. If you do have to transfuse blood and blood products, there is some evidence to say that it should be guided by TEG and ROTEM, but it's not a very convincing evidence. Now, one of the important things that you should remember, and this is an update in 2017, is that earlier there was a feeling that if your RBCs are dated, especially more than 14 days, then there's a risk of increased morbidity and mortality. But the current evidence suggests that the age of the RBCs do not affect the post-operative outcomes. Hence, RBCs of any storage time is good enough for transfusion. So what is recommended is that you limit your hemodilution in the perioperative period. You give routine use of antifibrinolytics, and tranexamic acid is a very good drug to give in this context. The transfusion of blood should always be based on the clinical condition of the patient rather than on any absolute hemoglobin triggers. And PRBCs of all ages are safe. And the multidisciplinary team approach using the anesthesiologists, surgeons, and perfusionists is always helpful in patient blood conservation management. What should be considered is you should consider aspirin in all patients, especially those who are undergoing CABG. If your center employs cell salvage, modified ultrafiltration, and retrograde autologous prime, they are good measures to try and decrease the perioperative anemia. Try and minimize the protamine that you give to patients for reversing the heparin. And what should not be done is you should not transfuse the erythrocytes or the RBCs to patients who are anemic preoperatively, and prophylactic FFP also has no role. With that, I would like to end my talk, and thanks for a very patient hearing. Thank you.
Hello, myself, Dr. Pradeep Kumar Goyal. I'm Clinical Director at Narayana Multi-Specialty Hospital, Jaipur, and Senior Consultant and Head, Department of Anesthesia and Critical Care. Today, I am presenting a topic, atrial fibrillation. What are the concerns for the cardiac anesthesiologist, as we all see. Atrial fibrillation is the most common cardiac arrhythmia, and it is basically a disorder of the electrical activity in the atrial myocytes. Atrial fibrillation, why is important? Because it causes a lot of complications, mainly like thromboembolic events, congestive heart failure, even death. And prevalence is very high. In the more than 60 years of age, it is 1%, more than 65 years, 7%. And once the age crosses 75 years, the chances of prevalence of atrial fibrillation is around 10%. So it is really a big problem. So we have to know, but basically it is an abnormal electrical wavelength originates from the left atrium and propagates in the different direction. And because of that, there is a disorganized atrial depolation and there is no effective atrial contraction. So mechanism is not that clear, but still few things are there in the research things. Like it is a non-uniform atrial refractoriness provides substrate for development of the atrial fibrillation, and also refractoriness of the atrial tissue facilitates multiple wavelength re-entry and instant intimation of the various regions of the atria through multiple re-entry pathways that results into atrial fibrillation. And here we are mainly discussing the atrial fibrillation associated with the cardiac surgery. So mainly we will talk about the post-operative atrial fibrillation. Especially in the post-operative atrial fibrillation, there is a mechanism, is the redistribution of the interstitial fluid into vascular compartment that also cause atrial stretch and predispose post-operative atrial fibrillation. So, and these changes also generally this atrial fibrillation occurs on the second postoperative day, and these changes also occur on the second postoperative day. And also systemic inflammatory response related to the cardiopulmonary bypass is also have a mechanism for this postoperative atrial fibrillation. As we all know, how diagnose this one? By pulse palpation, toilet ECG, Holter, echocardiogram. In our system, generally as a cardiac anesthesiologist, we use ECG and we just see the monitor and we find out, oh, this is the AF. On the ECG, P waves are absent. RR interval is variable. That is called irregular. Ventricular response is grossly irregular, definitely, you all know. And this is the picture. Just brief about the classification of the atrial fibrillation. Atrial fibrillation broadly divided into 3 or 4 categories, like paroxysmal atrial fibrillation that terminates spontaneously or with intervention within 7 days of onset. Persistent, that continues more than 7 days. Long-standing persistent atrial fibrillation that persists and continues for more than 12 months of duration. So paroxysmal is spontaneously or by intervention recovered in 7 days. Persistent more than 7 days. Permanent AF, the term when patient and clinician make a joint decision to stop further attempts to restore and maintain sinus rhythm. Both physician and patient decides, oh, now there is no chance of regaining the normal sinus rhythm. The patient will remain into the AF for lifelong. That is called permanent atrial fibrillation. One more category is also there, that is non-valvular atrial fibrillation. Atrial fibrillation in the absence of the rheumatic mitral stenosis or a mechanical or bioprosthetic heart valve or mitral valve repair. That is called non-valvular atrial fibrillation. There are a lot of predisposing factors for atrial fibrillation, especially valvular heart disease, right coronary artery stenosis, pre-operative digoxin, male gender, rheumatic heart disease, left ventricular hypertrophy, COPD. Respiratory is a very important risk predictor of AF. As I already mentioned, older age, diabetes, these all are the risk predictors. And why we want to manage atrial fibrillation? Why? Because first thing is very common, can lead to symptoms, and potential serious consequences may occur, like thromboembolism, impaired cardiac output, or increased mortality. So for that, we have to think about the management of the atrial fibrillation that includes prevention and treatment. So for prevention, most of the antiarrhythmic drugs used for the prevention of AF have their own drawbacks and side effects. Hence, prophylactic measures should be instituted only in patients at high risk of developing this complication rather than applying these measures as a routine for all patients. We should not give prophylactic treatment to all patients. We have to see if the patient's having some kind of risk factors, then we will think about the starting preventive medicines. The first drug we have to discuss for the prevention, that is beta blockers. Numerous studies have shown the beneficial effect of beta blockers. American College of Cardiology, AHA, European Society, everybody says beta blockers for prevention are the best. It is a class 1 or level of evidence A indication. So we have to use beta blockers. Second drug in the prevention is amiodarone. We all know Cardioversion. Significantly reduces the incidence of atrial fibrillation. Current guidelines says it is a class 2A indication or level of evidence A for postoperative AF for prophylaxis after cardiac surgery. Prophylactic amiodarone should be considered for patients with a contraindication for beta blockers also. Those patients we can't give beta blockers, we can think about the Cardioversion for prophylaxis. Other things are not that much confirmed, like magnesium therapy, shown to reduce the incidence, but current guidelines says there is no indication of magnesium. As we all know, digoxin has a very limited role. Statins, not that much, but people say you start preoperative statins One thing is important only in the cardiac surgery, that is the posterior pericardiotomy. It's shown useful in the prevention of the post-operative atrial fibrillation, as it allows blood and effusions to drain away into the left pleural space. So I don't know how many cardiac surgeons are now doing this thing, but previously I have shown few cardiac surgeons always when they just hemostasis, they just make one posterior pericardiotomy, and that helps in that. The next thing is the atrial pacing. We also use this atrial pacing as a prophylactic that is useful in the preventing atrial fibrillation by virtue of its favorable effects on interatrial conduction and atrial refractiveness. The reduction of the bradycardia-induced dispersion of atrial depolarization, which contributes to the electrophysiological substrate for atrial fibrillation. Atrial override pacing may suppress premature atrial ectopics and supraventricular tachycardia, and it helps in the prevention of the atrial fibrillation. Now we discuss about the treatment. We discussed about the prevention. Now we'll discuss about the treatment goals in the post-operative atrial fibrillation. That is prevention for the thromboembolism, control of ventricular rate, and conversion and maintenance of the sinus rhythm. So we have to have three goals: prevention of thromboembolism, ventricular rate control, and conversion. So first we talk about the aim of the conversion of atrial fibrillation. Conversion will relieve symptoms, improve hemodynamics, reduce the risk of thromboembolism, and long term it prevents the tachycardia-induced cardiomyopathy. That is very important. Atrial fibrillation follow-up investigation of rhythm management and rate control versus electrical cardioversion studies have shown that rhythm control was in no way superior to rate control in terms of mortality, morbidity, and quality of life. It was also shown in these studies that rhythm control does not prevent stroke. So these guidelines state that initial management of patient with atrial fibrillation includes anticoagulation as well as the rate control. Elderly patient rate control alone may be sufficient. Since postoperative AF is a self-limiting process, no long-term therapy is required in patients with the normal ventricular function and restored sinus rhythm. Based on above evidence, the only situation where the rhythm control is required is the patient remains persistently symptomatic despite adequate rate control. Situations in which adequate rate control cannot be achieved, and patient preference. Patient wants for conversion. He does not want rate control. Then it is an indication for going for the rhythm control. Rate control. Heart rate control is the primary focus in the treatment of postoperative AF. Control of ventricular rate can be achieved by beta blockers, calcium channel blockers like verapamil, diltiazem, and amiodarone. Routine beta blocker reinstitution is mandatory after surgery and should be done as early as possible in the postoperative period. Amiodarone is probably the single most popular drug used for the rate control after beta blocker. So the rate control main thing is the amiodarone. Rhythm control, what medicines we can use for the rhythm control: anti-arrhythmic therapy with procainamide, abutolide, propafenone is indicated for the conversion of AF into sinus rhythm for sustaining sinus rhythm after cardioversion. It is also indicated in the recurrent and refractory atrial fibrillation. Amiodarone still remains the chemotherapeutic agent of choice for rhythm control in post-operative atrial fibrillation. Next is the electrical cardioversion. Electrical cardioversion is indicated when post-operative AF is associated with hemodynamic compromise, myocardial infarction, ischemia, worsening LV function, rapid ventricular response. We can go for direct cardioversion, that is 360 joules for monophasic and 200 joules for biphasic, and we can go for this kind of cardioversion. Sometimes there is a failure to cardiovert. Additional measures we have to try, like we can increase the delivery energy, greater pressure applied to the pedals, go for internal cardioversion, or repeat cardioversion after giving anti-arrhythmic drug therapy. In such situation, initiation of antiarrhythmic drug therapy and correction of other contributing factors should be undertaken before attempting cardioversion again. Use of antiarrhythmic agent prior to direct cardioversion has the advantage to prevent recurrence. Because if we give antiarrhythmic drug, and then we will give cardiovert, the sustain of the rhythm chances are more. Anticoagulation, AF increases the risk of thromboembolism, as we all know, perioperative stroke. So, considering the limited duration of atrial fibrillation, clinician must weigh the benefits of anticoagulation against the risk of bleeding. Because here we are talking about the post-operative AF in cardiac surgery. So, bleeding is also there. So, we have to weigh between the risk of the thromboembolism and risk of bleeding. Anticoagulation can increase the risk of bleeding and cardiac tamponade. As we all know, as a cardiac anesthesiologist, the risk of increased bleeding may outweigh the benefits of the anticoagulation, particularly advanced age, uncontrolled hypertension, and history of bleeding. In these kind of risk factors, we have to rethink before starting anticoagulation therapy. So, to summarize, how to manage atrial fibrillation in a surgical patient, there are few things we have to keep in the mind, like continue beta blockers up to the day of surgery, including morning of the surgery. In the morning, we have to give beta blocker orally with sips of water. Restart beta blockers at the earliest in the postoperative period. In patient with high risk of chances are there, like age more than 65, COPD, previous history of AF, CHF, prolonged CPB, prophylactic intravenous immunotherapy may be started. We can think about pre-operative or preventive amiodarone therapy. In patients with fast ventricular rates and hemodynamic instability, immediate direct cardioversion is indicated. Once cardioverted, patient may be placed on the intravenous amiodarone after correction of any associated factor to ensure non-recurrence. If recurrent atrial fibrillation occurs, intravenous amiodarone or diltiazem therapy should be initiated along with the correction of the all kind of contributing factors. We have to think about the contributing factors also. Cardioversion may be tried at a later stage, like 24 to 36 hours later, if patient ventricular rate does not settle. However, if the patient remains unstable, another attempt at the direct cardioversion may be made after the loading dose of amiodarone is given. Chances of conversion will increase when you give antiarrhythmic drug and then you again attempt direct cardioversion. In patients with postoperative AF who remain hemodynamically stable with high ventricular rates, intravenous amiodarone therapy should be initiated after a loading dose. In patients with low ventricular rates, continue observation along with correction of all contributing factors. Amiodarone therapy may result in severe bradycardia if persist. 24-48 hour direct cardioversion may be attempted. Postoperative AF persisting the more than 48 hours is indication for a starting of intravenous therapy and followed by oral anticoagulation. In patients who have been cardioverted with a single DC shock or amiodarone, the drug can be discontinued after 7 days. In patients who have recurrent postoperative AF, amiodarone therapy may be continued up to 1 month. We can also think about the atrial fibrillation catheter ablation for symptomatic paroxysmal AF refractory or intolerant to at least one class 1 or class 3 antiarrhythmic medication. Thank you. Thanks a lot for this listening. Thank you.
A very good evening to everyone. At the outset, I would like to congratulate Team IACTACON 2021 for organizing this virtual event in a very successful manner, that too in a very short span. Thanks to the organizers. Ever since Wadenbeck et al. Challenged the wisdom of tolerating diabetes of injury, the literature has been flooded with basic and clinical research to address the merits and demerits of treating hyperglycemia in critically ill patients, especially in cardiac surgical patients. There are many issues involved in the management of diabetes in cardiac surgery, But what is clearly known is that there is a direct link exists between the uncontrolled hyperglycemia and unfavorable outcomes. So next 12 minutes, I'm going to talk about diabetes and cardiac surgery. There are no financial disclosures or conflict of interest in this presentation. The outline of my talk will be about a burden of diabetes, diabetes and cardiovascular disease, impact of diabetes and cardiac surgery, and finally about peri-op management of diabetes and cardiac surgery. As per the 2019 International Diabetic Federation, there are around 463 million diabetic cases in the world in 2019, which is expected to increase by 700 million by 2045. And very soon, India is going to be the diabetic capital of the world. In India, it is around 77 million, which is detected in 2019, and which is expected to increase by 134 million by 2045. The most worrisome issue is, out of the 77 million people detected with diabetes in India, approximately around 50% of the people totally unaware about the diabetic status. And more importantly, 70% of the cases remain uncontrolled in India. So only 25% of the Indian diabetics are under control with HbA1c of less than 7, and nearly around 70 to 75% of the patients with diabetes in India are uncontrolled, which may be the reason for increased incidence of macro and microvascular complications of diabetes in India. About diabetes and cardiovascular disease, and patients with diabetes are at 2 to 3 times higher risk for cardiovascular disease, and these cardiovascular disease, especially coronary artery disease and stroke, are the major cause of death and disability in people with diabetes. Due to endothelial dysfunction, arterial stiffness, inflammation, and oxidative stress, these diabetic patients can develop cardiovascular disease. The inflammation and hyperglycemic oxidative stress, insulin resistance, and its endothelial dysfunction, dyslipidemia, thrombosis, all can contribute for the occurrence of diabetic atherosclerosis, which maybe contributes for the occurrence of macro and microvascular complications like cardiovascular disease. About the impact of diabetes and cardiac surgery, the spectrum of in-hospital hyperglycemia varies from previously diagnosed known diabetes to a previously undiagnosed, which may be diagnosed at the time of admission, to an extent of stress hyperglycemia. So previously diagnosed and previously undiagnosed and stress hyperglycemia. About stress hyperglycemia, whenever there is a surgical stress, there is an increased counter-regulatory hormones, which reduces the release of insulin from the pancreas and ultimately leading on to occurrence of hyperglycemia. These stress-induced hyperglycemia also can produce endothelial dysfunction, immune dysregulation, and oxidative stress. And thereby, it increases the complications after surgery. So, out of the 3 groups of in-hospital hyperglycemia, the new onset hyperglycemia and the newly diagnosed hyperglycemia have a higher mortality compared to other 2 groups. So, these groups should be aggressively treated to reduce the complication after surgery. So, around 28 to 40% of the diabetics will undergo cardiac surgery, especially coronary artery bypass graft surgery, and these patients will have a higher incidence of stroke, renal failure, and sternal wound infection compared to non-diabetic population. In a retrospective study, for each incremental increase in intraop glucose by 20 milligram per deciliter above the 100, there was a 30% increase in the occurrence of adverse events. So whenever there is a hyperglycemia, particularly whenever there is uncontrolled hyperglycemia during cardiac surgery, it increases the risk of deep sternal wound infection, it increases the risk of arrhythmias, it also increases the risk of length of ICU stay and hospital stay, and more importantly, it increases the risk of mortality. So what is the optimal glycemic control before cardiac surgery? HbA1c of more than 7 itself is associated with the increased risk of post-op wound infection. But it would be very unrealistic to recommend that elective surgery be postponed in all such patients, even with the HbA1c more than 7. So, when the P of HbA1c is less than 8, in an elective surgical patient, it would be very appropriate to take up the case for surgery. And whenever the HbA1c is more than 9, if possible, it is better to postpone the elective cardiac surgery. But always keep in mind that the risk associated with the poor glycemic control should be balanced against the necessity for the surgery. About the pre-op management of diabetes, in the pre-op, other than duration of diabetes, control of diabetes, and complications of diabetes like CKD, autonomic neuropathy, and about medications, we should always look for silent myocardial ischemia, renal dysfunction, and autonomic neuropathy. So all oral antidiabetic drugs should be stopped at least 24 to 48 hours before any procedures. And when you stop these oral diabetic drugs, we should switch over to insulin therapy, which should be either basal bolus or premix regimen. And that insulin also should be stopped on the day of surgery, and we should switch over to the insulin infusion. So during the intra-op period, we should start insulin infusion along with the dextrose and KCl infusion, and the insulin dose should be adjusted with an hourly blood glucose monitoring to maintain the target glucose in the intra-op period between 140 to 180 milligram per deciliter. I usually maintain around 150. In the post-op, the insulin infusion should be continued till the patient resumes oral intake. And when the patient resumes complete oral intake, we should switch over the IV insulin to the subcutaneous insulin, either by basal bolus or basal plus regimen. But more importantly, sliding scale regimen should not be advocated in the perioperative period. When you switch over from IV insulin to subcutaneous insulin, we should start the subcutaneous insulin at least 2 hours before stopping the IV insulin. And we should establish the insulin requirements from the previous 24 hours requirement. The previous 24 hours total dose is calculated. From that, 50% should be given as basal insulin, and remaining 50% should be given as a meal-based boluses. So during in-hospital insulin therapy, the basal bolus regimen is the most preferred and ideal regimen to be followed. And basal insulin usually suppresses the hepatic glucose production, and bolus insulin suppresses the prandial spikes. About the sliding scale, as I said earlier, it should not be advocated in the periop period because it provides a supplemental insulin only after hyperglycemia occurs. It is a reactive approach, and it creates a roller coaster effect on the glycemic control. And it is always a non-physiological approach of controlling the blood sugar. So as per the American Diabetic Association and American Association of Clinical Endocrinologists, the glycemic targets for cardiac surgery in operating room as well as in ICU is maintaining the blood glucose between 140 to 180 milligram per deciliter. Various studies have clearly shown that the aggressive tight glycemic control by maintaining the sugar between 80 to 110 is not recommended because of its recurrent hyperglycemia and its related complications. So in a nutshell, in the pre-op, the choice of insulin regimen should be: in the pre-op, we should use basal bolus or premix, in the intra IV insulin infusion, and in the post-op from insulin infusion to basal bolus, and very rarely premix used in the post-op. So coming to the recommendation of Society of Thoracic Surgery, all patients with diabetes undergoing cardiac surgical procedure should receive an insulin infusion in the operating room as well as for the at least 24 hours post-op to maintain the glucose below 180, which is a class 1 and level B evidence. And patients with or without diabetes with the glucose levels more than 180 during cardiopulmonary bypass also should receive insulin infusion, which is a class 1 and level B evidence. And patients with or without diabetes with a persistently elevated serum glucose more than 180 during the ICU stay also should receive insulin infusion, which is also a class 1 and level A evidence. So to summarize, there is an exponential increase in the rate of diabetes prevalence globally as well as in India, with a very poor glucose control in Indian diabetics. And hyperglycemia during cardiac surgery increases free of morbidity, mortality, and recurrent ischemic events. And insulin infusion therapy should be a most preferred and ideal way of controlling the blood sugar during the intra and immediate post-op period. In that, basal bolus or premix regimen also preferred during the post-op after IV insulin infusion. And more importantly, practice of sliding scale regimen should be avoided in the perioperative management of diabetes. And maintaining serum glucose around 140 to 180, preferably around 150 with continuous insulin infusion significantly reduces the morbidity mortality in patients with the diabetes undergoing cardiac surgery. These are the references. The 25th Annual Conference of Indian Association of Cardiovascular Thoracic Anesthesiologists, IACTACON 2022, will be conducted in the Temple City, Madurai in Tamil Nadu. It will be organized by ACTA Madurai in association with ACTA Chennai. The conference venue will be Marriott Madurai. We are planning for a Grand Gala event after this pandemic, which will provide both academic as well as a cultural feast. On behalf of entire organizing team ACTACON 2022, I invite you all for the ACTACON 2022 at Madurai in February 2022. Thank you very much. I end this talk. Thank you very much.
Thank you very much, all the speakers. I thank all the speakers. May I please call upon Dr. Deep to just enumerate brief all these speakers and that he three homework. You have to unmute, Dr. Deep. We can't hear you.
Good morning. Very good morning from Canada. This is still morning here, but good evening in India. First of all, thank you so much to all the organizers for putting up a great show in such a short notice. Dr. Rajesh Arya, my dear friend Uday, and also thank you to all my friends who are chairing the sessions with me. And I would really thank that this is such a practical, very common, and very pertinent topics which the organizers have put up. Every one of us see these problems. There have been books written on all of these different issues. So I also thank all the speakers for doing a great job in such a timely fashion. Of course, we could go on and discussing, but very practical points, and thank you all the speakers for doing a good job. So a couple of points in each talks for anemia. I would say that Dr. Mishra very nicely elaborated. It is the patient blood management system. So I would tell that it is the team approach which is the crucial thing. Of course, as anesthesiologists, during the perioperative period, we can do certain things which are very nicely elaborated, but it is the team approach, and the major stakeholder, I would say, in my experience, is the surgeons. They see the patient much in advance before we see, so they know what the patient's hemoglobin is, so they have to be on board. We have had few experiences where we manage the patient nicely without transfusion, send the patient to ICU, and the first thing surgeon there says, okay, give 2 units of blood. Or when they see the patient pre-operative, hemoglobin is low, and they say that, okay, let us give 2 units before taking the patient. So we have to have the surgeons on board, along with, of course, perfusionists, and very important, the intensive physicians as well. Intensivists are equally important. The second thing I want to point out is the role of intravenous iron. We know in India and in many parts of the world, if patients are on proton pump inhibitors, renal dysfunction, whatever, iron deficiency is the commonest cause of anemia, and we should not take it lightly. Of course, we start oral iron, but if it is not working, we see that intravenous iron acts like magic, and within a week brings the hemoglobin up very fast. So that is another point I just wanted to make. Last point, the use of acute normovolemic hemodilution. This we have been practicing not for every patient because there is no evidence for that, but patients like who are coming for major aortic root reconstruction, like aortic aneurysms or chronic dissections, we find that if we take 2 units of patient's blood, if provided, of course, there are so many reasons or contraindications. If we take 2 units, the perfusionist makes them into plasma, platelets, and the RBCs. So that sometimes may have a role. Regarding atrial fibrillation, of course, very nicely discussed. I just wanted to point out about the risk for a stroke and prevention for that. There are a couple of scoring systems. One is the CHAD score or CHAD vascular score, which is congestive heart failure, hypertension, age of the patient, diabetes, and vascular disease. So according to that, we may have to start the patient on some anticoagulant for stroke prevention. Pulmonary vein ablation is very common nowadays. We know that mainly the non-valvular atrial fibrillation, most of the times the focus lies in the pulmonary veins, not in the left atrium. Of course, if left atrium is stretched, and that is a different reason. So if we can isolate those 4 pulmonary veins from the rest of the left atrium, electrical isolation, through the catheter ablation. So that is very common, and sometimes that is the first procedure to go. Lastly, about the diabetes, of course, the most common problem. Everybody knows that we should not go for very tight control nowadays because hypoglycemia is more dangerous than hyperglycemia. And Dr. Kumar very nicely mentioned that, of course, the glucose maintenance is between 140 to 180. Insulin infusion is always better than the bolus insulin. And one practical thing, of course, it is ideal to convert the oral hypoglycemic to insulin before surgery. But in my practical experience of over 30 years, I have not seen a single patient who has they've stopped their oral agents and converted to insulin pre-operative. That is my personal experience. And of course, if patient is on sodium glucose transporter inhibitor, that should be stopped maybe a little bit earlier rather than on the day of surgery. Yeah. So on that note, I will thank you. And there are many questions. So Dr. Uday can open the discussion for everyone.
A few of them you have already answered them. There's one question from Dr. Sanjita for Professor for Satyajeev Mishra. Is there any evidence of using 0.8 to 1 titration of heparin protamine ratio that you have mentioned?
Yeah, I think there were some studies. I think one study has come from probably Dr. Dheer's center also, where they have said that I don't remember the study. It was, I think, some few years back, where too much of protamine was associated with more coagulopathy, and hence they advocated for a more conservative protamine regimen. In our center, we are routinely we are reversing the total dose of heparin, but we give in a ratio of 0.8:1. So we don't find an increased risk of bleeding in the post-operative period. And anyway, most of these patients anyway get an APTT and get a PT-INR in the post-operative period. So you exactly know if your APTT values are elevated, you can jolly well give some more protamine. There was one more scheme of protamine. You give around 25 milligrams for around 6 hours after reversing the total dose of heparin. But the increased, I mean, the common consensus is that yes, you do tend to give a little less of protamine as compared to the total dose of heparin. So yes, I would advocate for that.
Thanks. Any other chairperson can come in and have their ideas.
I must congratulate all the 3 speakers for their effective and very good talks. From my point of view, I would like to ask one question for Dr. Kumar, sir. Sir, are there any perioperative risk factors, which actually increase the perioperative hyperglycemia. Patients who are not actually diabetic. That is one thing I would like to know. And the other thing is the insulin given on cardiopulmonary bypass to treat hyperglycemia is really effective, or do we need to give any extra dose or something like that? Or what is the mode of?
Thank you, Harish. Regarding the first question, without diabetes, are there any risk factors for occurrence of stress hyperglycemia?
Yeah.
Yes, of course, like other diseases, like other comorbidities, like age also a factor. And then whoever comes up with an emergency surgery, they are also under a high risk for stress hyperglycemia. And third one is the associated hypertension is many times push the patient to the development of stress hyperglycemia. These three areas we usually encounter with the stress hyperglycemia when the patient is not non-diabetic. When the patient is diabetic, obviously you know the reason that whenever there is a poor controlled diabetes with HbA1c of more than 9 itself, they are under high risk for developing any perioperative complications. Coming to your second question, regarding that insulin infusion in the cardiopulmonary bypass, it is not that the dilution produces more hyperglycemia or hyperglycemia. Whatever the sugar we are maintaining, we are going to maintain with the infusion. So there is no additional need for the cardiopulmonary bypass. Whenever there is a hyperglycemia of more than 180, during cardiopulmonary bypass also we should maintain that infusion.
Thanks, Dr. Kumar. Brigadier Vipul Sharma, any comment on newer drugs in atrial fibrillation that you know of than what we have already discussed?
Everybody is very familiar with the use of beta blockers and diltiazem and amiodarone for control of rate or rhythm in atrial fibrillation. But definitely newer drugs have come in, and ibutilide and vernaculant has been recommended now. And vernaculant is supposed to be, I have no personal experience with it, but it's supposed to be very good for acute onset atrial fibrillation, and has shown some promising results. So maybe over the next few years, more trials will be conducted, and then we'll see whether it's actually better than amiodarone. Other than that, I think maybe Dr. Pradeep would like to add something over it.
Yeah, definitely you said rightly.
Here, overshot the time. Just a last comment from Dr. Mahesh Vakamudi. Is he there? Mahesh?
Yeah, I'm here, Uday, and I think it was a great lecture, great talks from everybody. It was very nice.
Difference in blood conservation that you do at your center?
Sorry, Uday, I think I missed your comments. Sorry.
I said any other strategies that you use at your center for blood conservation? Or to prevent
actually, no. You know, what happened is over a period of time, bulk of your volumes becomes your op-cap, and then there's not much of blood loss, and there's not much of a concern. In the recent times, in the last decade or so, I think we moved out of our cell savers, hemodilation, autologous. All the techniques, I think, is long forgotten. You know, unless a center routinely does bulk of your volumes, a vascular surgery, major arch or major aortic surgeries, then you may probably think about doing any of the blood conservation techniques as what we routinely advocate for the vascular procedures. But I think as a mixed volume centers, I think we don't really practice any major blood conservation techniques. Even to an extent that we do not use any antithrombolytic.
Okay, that's good.
Antifibrinolytic, sorry.
Thank you. I think we already plus 2 minutes for this session. I thank all the speakers and I thank all the chairpersons for participating. And I hand it over back to the organizer.